Hey, it's that mama 5, living life, feeling alive. From kids to culture, news to tea. Real talk, real life, come vibe with me. That mama 5, she's got the vibe, yeah. Oh, 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 oh. You're watching that Mama 5, where real stories meet real life. Hey, it's that Mama 5, living life, feeling alive. From kids to culture, news to tea. Real talk, real life, come vibe with me. That Mama 5, she's got the vibe.
Hello everybody, hello and welcome back again to my channel. How are you guys doing? Happy Sunday evening. Yes, it's 10 minutes past 7 here. How are you guys doing? I hope you all had an amazing day. Right. Hello Andy, welcome. How are you? So this live stream is actually going to be very, very quick and straightforward. I was actually thinking of maybe doing a sit down video to discuss about this, but hello, Sister Vivian V. Welcome. How are you? Happy Sunday. I almost canceled this live stream because there's a particular show I was watching and which I was enjoying, but I just had to do this because I've wanted to do it since on Friday. Yes, so Sister Vivian, it's the weekend now. So again, I'm working throughout this week. I'm working from Monday till Thursday this week. So I might not be able to do any live stream, but we'll see. If I told you there's going to be live streams, it might be maybe later on at night. But I just had to do this one because I've postponed it. I've been postponing it for a few days now. And you guys know, according due to my profession, I just had to come speak about it. Yeah, I just had to come speak about it. So yeah, this is the second show for today, and yeah, I'm not sure if I've got a couple of videos lined up, but I'll probably do those over a sit down video. So, welcome everybody. How are you guys doing? Please like and share as you're watching. I would really appreciate it. Good evening, Mr. Sunday. Welcome. Happy Sunday to you. Mr. Sunday said, "Good evening." Finally, we have. Yeah, I was live this morning now, but you were not here. Oh, Savivia, you did. I was actually enjoying that one as well. But I was like, what? So this live show, hopefully, it won't be long. The only way it's going to be long is if maybe any of you want to have one or two things to say if I drop the link. But my target here is maximum an hour. We might not even do up to 1 hour. I mean, we're not even do up to 1 hour. But then, you guys know me. I really do enjoy. I don't enjoy creating live streams that is above an hour or an hour and a half. If it's starting to near 2 hours, it gets tiring, and then whoever wants to watch it, it might be too long for them. So I know there are some people who love the long live stream, but again, if you're watching it at the moment, it makes sense. But if it's for people who are going to come back and watch again, I don't like making my live streams really long at all. Maximum an hour and a half. Like if I push it, maybe 2 hours. But yeah, so with this one, I know there's a lot of shows going on tonight. In fact, there's a couple that I was watching and I really enjoyed watching them. So I just had to quickly come out here and do this one because, like I said, I should have done this video since I think is it yesterday or Friday when the news broke. But then I was busy with my side also and all of that. So here we are here. No worries at all, Mr. Sunday. Welcome. Anyway, let's dive into this story. You guys know the nurse in me will not let me let the story pass. I don't know, where was I? Was I driving home from work on Friday when I saw the news? And I actually saved the article. So anytime I come across any news that kind of like catches my interest, I bookmarked it on my phone because yeah, we all have our phones, and most news notifications that we see, you actually get to see those news via your mobile phone, right? So I think I was driving home from work that evening and I saw the news. I was just obviously sitting in traffic and I was like, let me just roll my screen. And then I saw the notification and I straight away, I bookmarked it straight away so that I can come back to it. And then I've gone on to social media, I've gone on to YouTube, I've gone on to Instagram, and I've seen a few gossip pages report the news, and I also saved it on there. So like, yeah, this is something I'm going to speak about. Even if I'm not doing a sit down video about it, I will do a live stream, whichever one that that I have the time to do, I will do it. So when I saw this news of this lady, I was pissed at the fact that some of these things have actually been happening. And you guys know there was a time I brought a story of how some Nigerian nurses who were being told that they could not work because apparently they believed that the exam they do was being written for them. A lot of nurses in the UK, Nigerian nurses in the UK, were affected by that. In fact, some people were told to stop, not to come back to work. Some people were being told they have to verify their exams. Some were told that they have to receive the exams again. Even some people who have had to receive their exams again, they've still not been, their employment were not confirmed. I think I did a live stream ago. And again, when I saw the news, it did not come to me as a shock because why? We all know what the education system is like in Nigeria. We all know, especially when it's university, if it is not SCX for grades and all of those things, we all know what the education system looks like in Nigeria. And again, if you actually go to school, like if you actually went to school in Nigeria, you studied hard, you should know that if you're an academic person, you actually go to school, like you enter school, correct, you go school, you learn for school enter your body, you enter school, you can be rest assured that anywhere that Nigerian goes, that Nigerian will perform at the top of any job they find themselves. Let me know if you agree with me in the comment section. Like somebody who actually went to school, who went to school with their sweat, like actually went to school, put all of their efforts in, and they study, they know for themselves that yes, I went to school, this was all my hard work. Trust me, there's nowhere they find themselves in the world. That Nigerian will always perform at their peak. Let me know if you agree with me in the comment section. As I said, I watched the replay. Busy schedule, busy Sunday, but it was packed with so much info. Oh, thank you so much, Savi. So, just like I was saying, when I saw the news of this lady, I was not surprised, and it's just 1 out of 10 or one out of 5 stories we've heard of. Some Nigerians who do not have who at the end of the day are not the owner of the certificate they come to study or they come to work with. And yes, again, let's go to the story first before I start to obviously welcome Ford, welcome. Let me share my screen with you so we can read the article together before I start to say the things that I know. Let me share my screen with you and let's read the article together. So as you guys can see on my screen, the news was reported by BBC UK, and it was reported on the 18th of March. So today is the 22nd, so I only saw this news on Friday. So according to the title, it says Dietitian didn't know where intestines were. Don't get me wrong, while I was studying for my nursing degree, I love every body system. The only body system that I struggled with and that I still struggle with, even though I am a qualified nurse, even though I have been practicing nursing for almost 4 years, the only body system that I don't like, and I'm not ashamed to say it, is the cardiovascular system. The cardiovascular system is very, very massive. It's huge. And at first, when I was a student, I had a placement in a cardiology ward. And there's a lot that happens there. There's something about rhythm of the heart. Are you sinus rhythm? Are you A3? Are you AF? Are you whatever? When it even comes to reading the rhythm of the heart, I struggle with it. It needs to take another training on its own. So out of all the body systems that were taught while I was trained to become a nurse, the only one that I ate then and now that I struggle with is the cardiovascular system. I know the cardiovascular system to a certain extent, but there are some aspects that I did not even bother my head. I would have maybe be concerned or bothered myself if I was going to work on a cardiovascular ward or if I was going to work in a cardiology ward. But since I don't intend to work in a cardiology ward, I did not I did not even bother my head into going to deeper like AF, all of these cardiac issues, whatever. I did not even bother myself. I did adult nursing, which means that adult nursing compromise of a lot of different angles, different departments when it comes to nursing. Okay, but let's get there. Mr. Sunday said she was misled, but better yet, full of ignorance herself. Misled how? We're going to get there. Mr. Sunday said we'll check out. Okay, Andy said it had here in the it's had here in the US. So many nurses, not just Nigerians, were being investigated for fake licenses. So let's read the story of this lady. So the article continues saying that a dietitian who could not explain where the intestines were or what a gallbladder did was able to get a job at the Manchester Royal Infirmary (MRI) after lying in her applications. And now, why I said I was not surprised because there's a lot of NHS interview coaches here on YouTube. They will ask you to come and join their WhatsApp group so that they will coach you on how to answer NHS interview questions. You can imagine paying a YouTuber here who has a WhatsApp page. Pay so. I will coach you on the questions you'll be asked for your interview. So you can imagine somebody who does not even have the knowledge of the job they are going for. Somebody is coaching them. Interview questions, NHS 20 interview questions you'll be asked. And yes, there are some pages here, there are some channels here on YouTube, even on TikTok, who are selling all of these training things. They would say they will help you to format your CV. Whatever it is they are putting in your CV, you might not even have the qualification for it, but they will help you format your CV so that it meets the job description that you're applying for. So at times, most of them don't even necessarily have the skills or the qualification, you know. So let's continue. So it says that Ifeanyiwa Undule Nonso was sacked in August 2024 after an investigation. So apparently this case has already happened. It's been investigated. It was after the outcome of the investigation that this news was released. And that's how most cases in the UK happens anyway. So she was sacked in August of 2024 after an investigation found she was unable to answer basic questions about anatomy or how to help patients manage common conditions. And again, nurses are not trained to diagnose. However, we are trained using the A to E assessment to figure out symptoms at times. And don't get me wrong, there are some symptoms. A patient might be going through something, they might not have symptoms. It's just like at times when I'm in recovery and I'm looking after a patient and their blood pressure suddenly drops to like 84, 85 systolically. Be rest assured that there are some people, if their blood pressure drops that low, they might feel lightheaded, they might feel dizzy, or they might even collapse. However, there are some people whose blood pressure will go that low and they will not have any symptoms. So again, if they don't have any symptoms, your job as a nurse obviously is to ask questions that you will see in somebody who could experience symptoms of a low blood pressure. So like I said, for example, the blood pressure might go from 110 systolic to like 75. And some patients will not have it because if you ask them, do you feel lightheaded? Do you feel drowsy? Do you feel dizzy? They'll tell you no, and they're chatting away. For the fact that they don't have symptoms does not mean that you should not keep an eye or you should not let the anesthetist know. For me, I normally don't get worried when things happen like that. I will not make a judgment after one reading. I will make a judgment after the third reading. If the third reading remains 75 or remains low, then normally we have something called emergency drug, where once a patient has had surgery, there's a list or there's a checklist or there's a form, a paperwork that comes out with the patient where the anesthetist has already signed all of these emergency drugs that we can use in case of emergency. So yes, a systolic pressure in 10 minutes that remains constantly below 85, you will have to do something. Some anesthetists might be happy for you to use. So if the patient has symptoms, you might need to give some medication to help push the blood pressure up. For me, in most cases, if the patient has symptoms, I just don't go for fluids alone. Yes, you need to apply fluid. I just don't go for fluid alone. If the patient has symptoms, I will need to give some sort of medication to help boost the blood pressure, and then I'll hang a bag of fluids. And once I've done that, I will let the anesthetist know what has happened and what I've done, and if he wants me to remain on that part. So yeah, I digress. Anyway, so she has now also been struck off by regulator by she has now also been struck off by regulator, the Health and Care Professions Tribunal Service (HCPTS), after a panel concluded she had shown premeditated and sustained dishonesty. Manchester University NHS Foundation Trust, which runs MRI, said no patients had been harmed and it had since strengthened its recruitment process. Ndole Undoso applied for the job as band 6. Band 6. She even high passed me for grading. Okay. As band 6, you can imagine how much she's going to be getting paid as a band 6. So Nundule Ndulue Nonso applied for the job as band 6 rotational dietitian and was the only applicant interviewed in September 2023. The tribunal heard that during the application and interview process, she came across as confident and scored 28 out of possible. I wouldn't be surprised if she's one of those people who went to one of those TikTok and YouTube coach. I will help you to format your interview, your CV. I will coach you and train you on the questions you'll be asked when you go to interview. I think that is possible. She's probably maybe a victim or one of those people. Allegedly, alleged. Guys, please like the live stream for me. I really appreciate it. Michael said, I blame the coaches on social media. Exactly. That's where I'm actually driving this live stream to. For whatever job you'd want, that's why medical malpractice and incompetency rule the day. If you see the pending case at Innocent United and RCN, you will faint. Or more, if you go to RCN website or NMC website, you will see cases of nurses that have been struck off. It plenty, no be small thing. Eddie said asymptomatic or their BP is usually low. So normally when patients go for surgery, a lot of things could impact what their normal readings will be. Either for the fact there are some people, normally they might have a regular blood pressure, maybe systolic pressure of maybe 120, 140. And then they come into hospital, and because they know because they are anxious, their blood pressure might skyrocket to 220. And I think we call it white coat syndrome in hospitals, or when they are in an hospital environment, automatically, because they're in that environment and because they're anxious, their blood pressure will drastically, increase. Yes, surgeons and institutes will understand that because they will have monitored their previous what they had normally. So in cases like that, situation blood pressure of maybe 200 something when they are in hospital, it will not stop the surgeon from carrying out the surgery, but they'll keep an eye on it. However, so if such patient now comes to me in recovery, if I look at the trends of their blood pressure while they are in theater, if it stabilizes, if it is 100 and above systolically, or even if there's one reading of systolic pressure of 85, I might not be equally concerned. But if they've come out to me in recovery and I've looked at their trends and they were above 100 systolic, and then maybe 10 minutes into when they were in recovery, their blood pressure dropped to 85 or 84 systolically. So when they are in recovery, if their blood pressure drops to below 85 systolically, I will have to do something, because I have the form to apply emergency drugs. I don't have to wait for the anesthetist to come do anything. There's a yellow form with a signature that allows me apply, emergency drugs. And then, just like I said, if they come out to me after 10 minutes, if their blood pressure drops like below 85 systolically, as a nurse, I will need to go and look at what their blood pressure was during their pre-assessment. That will be the first time they came to hospital to confirm that they'll get their surgery done. I will look at their blood pressure, and then I will look at their blood pressure from when they got admitted into hospital to get their surgery done. So ideally, they will have arrived into the hospital the night before their surgery. So which means while on the ward, they will have had their blood pressure done every 12 hours or something. So I'm going to go look at their news chart, which I already have in all of the documentation. I will check what their blood pressure says. If the systolic pressure says above 100, maybe 120, 140, okay, it's still making sense. And then I'll go into the trends of while they were in theater. If they are both 100 systolically, and if the anesthetist has not told me otherwise about maybe he has to use ephedrine or he has to use anything to help, the blood pressure. If he's not giving anything, I won't be concerned either. However, I will not do anything with the first reading. All I need to do is make sure that the heart rate is, the heart rate is not, they're not, it's not below maybe 43 or something. Ideally, again, if the heart rate is low, I'll be concerned at that instant. But if the heart rate is strong and healthy, I won't be concerned. So the first reading is not going to get me panicky, but I'll keep an eye on it. I'll ask the patient if they feel otherwise, how they are feeling at that moment. If they are chatty, if they are not drowsy, then I'll wait for another reading. If the second reading stays below 85, I'll still keep asking them if they've got any symptoms. Like I said, some might have symptoms and some might not have symptoms. I'm not rushing to give medication because I have checked what their blood pressure was before they came into hospital for surgery, and it was above 100. I have checked their trends for when they were in hospital, when they came in the night before their surgery. Their blood pressure was okay. I have checked their trend for when they were in theater. Blood pressure was fine, and their anesthesia did not report otherwise. So by the third reading, if the third reading stays below 85, then I will have to do something. For me, at that instance, if the patient is chatty, if they don't have any symptoms, they don't feel drowsy, they don't feel lightheaded, when it happens like that, I will normally tip the head of the bed. I will tip it down. I'll tip the head of the bed down, and then I'll hang up a bag of fluids. So once the bag of fluid is going on, yes, they might be dehydrated because they've been fasting. So these are effects that could affect them, obviously. And all of the, they've had propofol, they've had all of these things in theater. So these things could potentially add to their blood pressure, dropping. So if it happens like that, they are chatty, they don't have any symptoms, they are chatting, they are fine, heart rate is fine, they are not on oxygen, I will put a bag of fluid up. So with that, I am still not convinced in a way that I should be giving them emergency drug like ephedrine, because apparently they are chatting away, their heart rate is fine. Again, while the blood pressure, while the bag of fluid is up, I will go speak to the anesthetist to say, this is this, this is this, this is this, no symptoms, blah, blah, blah. Bag of fluid is up. Do you want me to give some ephedrine? It's up to the anesthetist. So the question the anesthetist is going to ask me is, what is their heart rate? Is there any symptoms? So if he agrees with me that, oh, maybe consume with the bag of fluid, give 250 mils of bag of fluid. If after 250 bag of fluid, if the blood pressure is not getting better, give ephedrine. And that's what I will do, because I've already sought, second opinion. So maybe if after infusing 250 mils of fluid and the blood pressure still remains 75 or below it, ideally, if the blood pressure is below 85, we'll have to do something. So if after doing 3 blood pressure, in 15 minutes, 250 mils of fluid and the blood pressure is still not increasing, at that instant also, I will encourage the patient to start drinking. I will offer them a cup of water, cup of tea or something. I will give that. And then I will encourage them to drink. See, even after I've done all of that and the blood pressure is not coming up, then I will have to give ephedrine. I will have to give ephedrine. So yeah, that's some of the things we do in theater, in pre-op or in recovery. So let's continue with this lady's story. So yes, so with her interview process, she came across as confident and scored 28 out of a possible 45 points. In her application, she had described how she had, in quote, in-depth knowledge of providing dietary support to specialties, including endocrinology, gastroenterology, and artificial feeding. She also said she had experience of providing medical nutrition therapy to help patients manage conditions including malnutrition, HIV/AIDS, cancer, colic disease, irritable bowel syndrome, dysphagia, which is difficulty swallowing, and eating disorders. She was hired and started work on 19 February 2024, having moved to the UK from Nigeria. The panel head the hospital also received satisfactory references from her previous employer. However, on 28th of February, a line manager, Curtis Jones, returned from annual leave and held an induction meeting with Undule Nonso, where he noted her description of her previous job did not match what she had written in her application. See, again, it goes on to show that either our CV was jumped together by those TikTok advisors and coaches. Maybe somebody wrote her CV for her, maybe somebody wrote her whatever for her, and then she got caught out. So the tribunal held a supervision log had already been started by other senior staff concerned about her apparent lack of knowledge. I trust the colleagues, they don't lack. When they start experiencing some irregularities with your practice, with what you say you know, and you're not doing it, they will start speaking to somebody and they'll start taking logs. There are some people like that who will take it as their business. You might not know. They might not even share with other people that that's what they're doing. But someone will actually start to they will actually start to keep logs of some of the things they've actually noticed about you. And once that concern grew, that's when you get reported. So an investigation was launched and also was spoken to by a number of senior staff. One, critical care dietetic clinical lead Lorna Awood told a senior colleague she believed Nonso did not know the fundamentals of dietetics, such as medical conditions, biochemistry, and medications. It was Awood who asked her what organ came after the stomach. And after some prompting, Nonso incorrectly answered the large intestine. Awood told the tribunal she was extremely concerned because this is basic anatomy, which is fundamental to the role of dietitian. Trust me, the role that she went for is a very specialized role. And as a band six, she did not even enter as a band five as a specialized role. So you need to know all of the anatomy of, the what's it called, the nutritional, the how the intestine work. You need to know all of that. It's not just about treating that patient. It is about if those things you're about to apply goes into the wrong part of the body, part of the stomach. How would you know? What would you do? So if she does not even know the basic of how the stomach works or the components of the stomach, then that's a red flag, or that's an issue on its own. But let's continue. She also said she found Nonso could not calculate a BMI. Can you imagine a BMI? She could not calculate a BMI correctly and did not know what the symptoms of dysphagia were. So that's dysphagia is difficulty in swallowing. So she is not able to calculate a BMI correctly and did not know what the symptoms of dysphagia were, which are basic things she should know based on that job role she applied for. She could not, it's just like me working in recovery, and I do not know when I should see, I did not know the difference between a healthy heart rate and a heart rate that is not healthy. So let's say, for instance, I'm looking after a patient in recovery and the patient's heart rate is dropping to 30 and I'm sitting down there not doing anything. That is me failing woefully in my skills, because somebody with a heart rate of 30, that person is slowly slipping away. In fact, your monitor will be beeping. Bang, 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 bang. The way our monitoring system has been set up at work, if the heart rate starts to fall below 43, the monitor will start screaming. Except if maybe the patient has a pacemaker or something that is set at a normal heart rate. But if the patient does not have any cardiac issues, there is nothing wrong with them, and their heart rate is suddenly going to 40, 38, 39, 37, and I'm sitting down there not doing anything, then I am failing in my skills. I am failing in my monitoring skills because I need to be either on the phone to the anesthetist, or I am shouting for people to come help me. That's why is the heart rate falling? Especially if, like I said, if nothing was passed across by the anesthetist, especially if you've looked at the patient's record and there's no reason why their heart rate should be falling. It's a different case if they are still drowsy after coming out of theater, because obviously they see propofol and all of these things. Sedatives is still in their system, so they are still heavily drowsy. It's understandable. But if they are sitting awake, chatting away, and the heart rate is dropping, then you want to get the anesthetist into recovery straight away to come review that patient. So if I'm not doing that, then my monitoring skills is actually failing, or is beclouded, if that's a word. So they continue. She could not tell me the risk of allowing somebody with dysphagia to eat standard diet. She did not know how to dietetically manage refeeding syndrome. She could not interpret biochemistry, and she could not interpret symptoms, Ewood said. The tribunal heard when staff noticed she was struggling to identify types of feeding tube. She said they were different in Nigeria. They'll be different, but then again, you will know which one is mostly used. And the only thing that will make them different with the one they use in Nigeria is probably because of the maybe manufactured, what manufacturer, or you will know. You will know. And if you don't know, which I'm going to be getting there at some point, if you don't know, there's no harm in asking. But I'm going to get there, okay? Nonso was suspended in March of 2024 and sacked in August. In her evidence to the tribunal, Nonso claimed she had some knowledge of the Band 6 rule, but accepted she did not have an in-depth knowledge. When she was questioned by the tribunal, she was asked what a gallbladder does and incorrectly replied that it was part of the kidney. Voila. She said the gallbladder was part of the kidney where urine is stored. Guys, she said the gallbladder stores urine. Like, how did she get that job? She said the gallbladder stored urine. Like, how? How? And I want to believe that the nursing school in Nigeria is very, very thorough in their training. And these are some of the things that you would not even expect even a newly qualified nurse not to know. But let's keep reading. So, the article continues, in fact, the gallbladder is located below the liver and is involved in storing a bile. Like me now, I don't have my gallbladder anymore because I had gallstones in it. And yes, I had surgery last year to get it out. So my bile is just dripping into my stomach. And I'm one of those lucky people that even with that, if you've had your gallbladder removed, you will know some people will always have constant diarrhea, because apparently the gallbladder is where the bile is being stored. Now that I no longer have it, the bile is just going to be dripping into your stomach, which means that some people, anytime they eat, they will either feel as if they've got like a sour taste at the back of their throat. And if it's starting to happen frequently, they either need to go back to their doctor, or something needs to be done. Or some people will currently feel nauseousness, they will feel sick after each meal. Or some people they will keep running to the toilet after any meal. Like anytime they eat, the food will just run through them. These are some of the effects of not having your gallbladder. But for me, since I've had my gallbladder removed, I have never ever suffered any of those symptoms. I eat anything and I don't have any side effect from. So the hospital trust said Nonso was registered with the HCPTS at the point of employment. It said concerns were raised by staff within a few days. A spokesperson added, "We ensured she was always supervised in the workplace as we conducted a rapid fact-finding exercise, following which swift action was taken, and she was removed from her post." So that's the story about Nonso. And again, just like I said, nurses have not been trained to diagnose anything. You have been trained to identify symptoms, even illnesses, and that's why we've got the A to E assessment. If you have a patient that is deteriorating, or if you're looking after somebody, A to E assessment is a tool is a basic tool that every nurse should know. There was a time there I was looking after a patient who had a hip, patient suddenly started to deteriorate, and I had to go. We've done everything we could at that point, and we could not get the patient to settle. So we had to obviously involve some of the medical staffs in ICU and stuff. Even doctors who have had years of experience as anesthetists, as consultants, they still use the A to E assessment. They still use the A to E assessment in assessing the patient airway, breathing, circulation, disability, exposure. They still use the A to E assessment. If they don't sort A, they can't move on to B. If they don't sort B, they can't move on to C. If they don't sort C and be satisfied that there's nothing in C, they can't move to D. And if, like I said, they can't move from one stage to another if they don't have the clearance from one section. Say, okay, airway is fine, patient is chatting away, so there's nothing wrong with the airway. B is breathing. Is there any seesaw breathing? Are they breathing with the muscles in their stomach, or is there is the lungs leveled, or is one lung working than the other? There's a way they check it for seesaw in the stomach to be sure that they are not using the abdominal muscle to breathe. Once that is clear, they don't have an issue with breathing, they move on to circulation. Circulation, they check that there's no blood flow. They check for the capillary refill time. If it's less than 3 seconds, they know there's no issue. They check for there's a way they carry out other checks. They use a what's it called, stethoscope, to check if the patient, like, their highs and all of that. If circulation is fine, they don't have any issue with circulation, they go on to D. Is any disability? As the patient going disability, can they speak, can they move? Is there any part of the body that is not moving, that is not functioning? All of that. If all of these stages are not equally assessed and certified that there's nothing wrong, they can move on. And even after they've done A to E, and mind you, while they are doing A to E, there will always be something. Okay, let's say maybe at some point, patient's blood pressure keeps dropping, and we've given tons of bags of fluid, and blood pressure is not getting better. Eventually, that patient, by the time they were able to know, they carry out MRI, they carry out ECG, which I was able to do that day. They carried out, what was it again? They carried out a lot of things, arterial blood gas. They had to put an arterial line in to go check an arterial blood gas to be sure maybe the patient was retaining CO2 or stuff like that. They did all of that while they were going from stage to stage. Still, they were not even able to come out with something. Eventually, I was looking after that patient for over 4 hours, because at the end of the day, in 1 hour that I've been looking after her, blood pressure started. I still did all I have to do. When I realized that all I have to do was not working anymore, I had to seek for help. And then the ICU doctors came in. In fact, there was 2 of them, and all of their juniors came in as well, all over this patient. And eventually, the following day, we found that patient was bleeding inside. Patient was bleeding inside. That was it, because they had to go do MRI. Is it MRI? Was it MRI or CT scan? They had to go do something overnight, because obviously, as a nurse, there was nothing I could do anymore, because they've already taken over the patient. So they had to transfer the patient from my care in recovery to ICU. because patient was she was in a lot of pain. They were giving her everything, and none of these things were helping. So when I came into work the following morning, I checked to ask what happened. They were like, yeah, they found out that the patient was actually bleeding internally. So she was losing a lot of volume in terms of blood. It was an intern. She had a joint replaced, but and I was saying to them that how was she bleeding? We were checking all over. They were like, well, she was bleeding internal bleeding. Something must have happened during the surgery. So that was that. At least that way, I was able to figure out that blood pressure is not getting better. I've given emergency drug. I've given fluid. Patient is chatting away. I've given everything I could do, but then the blood pressure was not getting better. And at some point, she started to deteriorate. Her saturation level was dropping. Her heart rate was dropping. And at that point, I just knew no, I need to get somebody in. And I was glad I did. In fact, that patient, I was not actually the one who started looking after that patient. I was just passing by. It was another colleague of mine that was looking after that patient. It was when I saw the blood pressure drop, I was like, what's going on? And I walked over to where the patient was. And that was how I took over because, again, the nurse that was looking after her was going to leave. She was finishing her shift. So, nurses are not trained to diagnose any sicknesses. However, you are trained to monitor, to know the basic rate or basic level of what is a appropriate blood pressure. What does a blood pressure needs to look like before before you raise an alarm? And don't get me wrong, there are some patients who are maybe people who have cardiac issues. At times their blood pressure will be in the 70s and they're absolutely fine. In fact, their doctors will tell you, don't be concerned if the blood pressure is like 70, 75, that's their norm. Yes, because they have an underlying cardiac issues. And there are some 70 something is deadly for them. You need to be doing something. So again, in this case of Nonso, she claimed to have worked as a dietitian before, and then she applied for that job as a band 6. And trust me, I've always said this, every job you take in the UK, you might claim that you have your own skills, that you've worked somewhere else before, you still get trained. You still get trained. When I became a nurse, I was a newly qualified nurse. I started at my work as a newly qualified nurse. I had in-house training for 6 weeks. I had in-house training. Like my hospital, they always like to be extra. See the skills you said you have before where you were coming. When you join my hospital, you will need to go through my hospital's own training. Like my hospital like to be extra. If you said that you've been trained on how to do ventilation and cannulation, when you start at my hospital, you will have to do our own hospital training again. They call it, I don't want to call them on my hospital, but yeah, they say so training. You will still do it. If you say you have a skill of applying catheter, when you start at my hospital, you will still have to do that training again. You will still have to do that training again. So if you say you have a certain skill or you have a level of training for a certain job you're applying for, when you start at another job, you should still be trained. The training, because you claim that you have that skill, it might not be a long-term training, it might be maybe 3 weeks. And then, even though the training is short, you might have to maybe shadow somebody just so they know that, okay, you have this training. We've only given you 3 weeks of training, but then you need to shadow another member of staff for another 3 weeks just to be sure that you learn what we actually do in this part of this department. And I would imagine that the same would have been done for this lady. Or maybe it was not done. But then, again, there is no harm in asking question. Vivian V said, I personally think everyone who's been under her care should press charges. Make a good example of her. Imagine if she advised a patient wrongly and something went wrong. Quacks choosing money. That's a good one that you mentioned there, but I would imagine that since she was being suspected by her colleagues, I would imagine that they wouldn't have allowed it guns on the same whereby a patient will come to harm. And the article has not mentioned anything about maybe somebody was harmed or anything like that. So, like I was saying, if you don't know something, there's no harm in asking questions. Like I'm going to keep referring back to myself. I've been a nurse for 3.5 years now, and it was only a year and a half ago that I was confident in taking out an arterial line. And you guys know an arterial line is where they put a like a vein flowing. They put a vein flowing into your artery. And the main purpose of putting a vein flowing or a line is an arterial line into your artery is to monitor your blood pressure by the beats. They monitor your blood pressure by the second. You can imagine if you're going to a surgery that's going to last 10 hours. You don't want the blood pressure cuff to be going off every second on your arm. So instead, they put an arterial line into your artery, and then it will monitor your heartbeat by the beats. By the beats. Again, because it's a line that goes into your artery. Me, I'm always very, very like, God forbid anything. Somebody bleed, that person will buy you. So I was always like, no, I'm not confident. Yeah, like I said, was anytime I've looked after a patient who has an arterial line in, again, if they're going back to normal ward, the arterial line has to come out. And then if it has to come out, I was not confident in doing it. It's been done several times. In my head, I know I can do it, but I was just not confident enough that what if this patient bleeds out? What if I did something? There's always that what if in my head. But then again, when I decided to build my confidence to start taking that, I will ask senior members of staff to come watch me do it. Or if I want to do arterial blood gas, which means that I will need to draw BLOOD out of that arterial line. Because again, it's a line that goes into your artery, and the artery goes straight to your what? Is the artery that passes blood straight to your heart. So you don't want to mess up with that line. So if you need to say, oh, can we take a blood to go do blood gas? I'll be like, I will need to go and find some of my senior colleagues to come and do it. But gradually, I build up my confidence. The first time I attempted it, I asked one of them to speak to me, talk me through it. They talked me through it, and I was able to do it. And then I asked them multiple times to talk me through it, because I want to be satisfied with myself that yes, I'm doing the right thing. And because I'm asking does not mean that I am dumb. I am just gaining that confidence as I build my skills. There was a time there I think I was off work for like almost 14 days. I was on annual leave, and I came back, and my first patient was a patient that had an arterial line. I still had to ask one of my senior staff to come and look at me while I'm taking blood and while I'm removing it. There's no harm in asking if you don't know how to do something. I would rather ask for help or ask to be supervised while I do something than cause harm to a patient, because that is the most dangerous thing. You don't ever want harm to come to somebody you're looking after when asking a question could have saved you that. Same thing goes to PIC line. Till now that I'm speaking to you, I don't like touching the PIC line. At times, they put PIC line in when patients have maybe veins that are not strong enough. They can't put a line through it, or every time they try to put a cannula, the veins keeps breaking. Like patient with poor veins and stuff like that. In major surgeries, they will put a PIC line in. But then I think I've only had to look after a patient with a PIC line, maybe not a lot, but in most times I've had them. I try as much as possible not to put any medication through it, because you don't want to use the wrong one. And yes, the one that you're supposed to use, there's a color code, there's a color code button or something that tells you which one you can use and which one you can't use. Or when you are drawing blood, like I don't, even tomorrow, if I enter work tomorrow and they tell me to take blood out of my PIC line, I will say no. Somebody else should come and do it, or maybe somebody should watch me. So she knew she doesn't know how to do all of these things. Why was she not asking for help? Why was she not asking that, you know what, I'm sorry, I'm not quite confident doing this. Can you talk me through it? Can you show me how to do it? And if it is something you don't know how to do, she could have at least said to her management and said, you know what, I'm not confident on how to do this. I'm not quite certain. Yes, it's different from where I've come from. So can you maybe put me through a training on how this is done? See, even if she asks, I'm sure they will have put her through a training. But going to do something, and they ask you a question like, what does the gallbladder do? Say the gallbladder is store urine. Like, seriously? It just obviously goes to show that she's one of those who went through school through the back door. The job she went for, yeah, she might be a qualified nurse, but then the job she went for, she does not have the skills to do it. That's why the dangers of all of these NHS coaches on YouTube and on Instagram, on TikTok, oh, join my WhatsApp group, pay £250, pay £50. I will coach you on your NHS interview questions. I will coach you on what they will ask you. You saw that they said that she passed well. She appeared confident because she's been coached. Confident because she's been coached. And then where I read the article on Facebook, come and see lots of people talking, oh, that's what happened when they get cheap labor from Nigeria. That's cheap labor from Nigeria. Most of them do not go to school. Most of them they have fake certificates. And then again, anywhere you mention Nigerians, what do they know Nigerians for? They know Nigerians for fake documentation allegedly. That's how they know Nigerians. If they want to describe Nigerians now. So now people are saying, oh, it's because of our actions, there's going to be lots of scrutiny. Come, like I said, if you actually go to school, you studied and you know within you that yes, you went to school, nobody said the one way you went, where people they write exam for you. Anywhere you find yourself at a job, you will perform perfectly well because you know what you're doing. And again, like I said, where I worked, I started as a newly qualified nurse. I was given an in-house training. Even all of the in-house training that was given while I was training to be a nurse, I already had those training. I already had those skills and experience when I went for all of my clinical placements. No, you go for clinical placements in hospitals, you see how they mix antibiotics, you see how they, nurses here in the UK, we hardly give injections, except for maybe except for what's it called, dalteparin or stuff like that. We don't give injection like they do in Nigeria. We don't. Mostly there's a cannula, you just pass your fluid and stuff like that. Most injections we mix it, we give it as IV. We don't give injection the way they give in Nigeria. So I still have to have an in-house training, even though I had all of these skills while I was training during my nursing training. I was trained on how to do catheterization, female catheterization, male catheterization. I already received those training. I received the training on how to take blood, how to put a cannulation in, and I see how to do the training all over again, which I don't see it as a bad thing. To me, it's helping me build my confidence. But then again, as a nurse, if there's anything you're doing, if you're not sure, if you're not confident about doing it, it's better you ask a question than go ahead and do something and that thing cause harm to the patient. Because trust me, your registration will go and the hospital will throw you to the boss because they will ask you, um, who did you ask? Did you ask anybody for help? Guys, I want to quickly take this call. I'll be a second. Sorry, guys, I ordered pizza and I did not put my door number. The guy would have just been wondering where am I taking this food to, so they were calling to confirm the door number. So just like I was saying, there's no harm in asking if you don't know something. In fact, there's been several times even at work, obviously when I was just going to qualify the first year of my nursing training, there's a lot of stuff that I was not confident about doing. And whenever I'm being asked, I would tell them straight away, I'm sorry, I don't know how it's done. There was a time I was moved to a ward to go work on the ward. Obviously, they were short staffed and they asked me to go there. Immediately I got to the ward, they were like, I've got the nurse I was meant to be helping. She was like, I've got 4 continuous antibiotics. So you're going to make so antibiotics. Immediately, me that I didn't want to go to the ward because since I've become a nurse, I've never worked on the ward. And I was only on the ward as a student. And I knew that working on the ward is not for me. So you can imagine I've been working where I work for over 2 years, and suddenly I was sent to the ward to go help them. I felt totally lost. Like it was as if they yanked me and placed me in the middle of an ocean. I was like, how am I gonna like what am I supposed to be know? What do I know to be doing on the ward? Yeah, if you ask me to go and help you to to do all of your observations, I will help you to do it. If you ask me to go and maybe run a fluid, I will do that. But anything else, I mean, if it's to do the medication round, yeah, maybe I can do the medication round. But when it comes to like antibiotics, because in my department we don't do stuff like we don't mix stuff like that. Yes, we make up pain medications like maybe morphine into a pump. We give analgesics via the IV line. We set up fluid, but antibiotics, we don't give antibiotics in recovery. We don't have to, in my department, I don't have to make up antibiotics. It's the anesthetists that do that while the patient is in theater. So if the patient is meant to have antibiotics, the theater or the anesthetist already give it in theater before the patient comes out. So I have never had to prepare an antibiotics before. So you cannot imagine me being moved from a department where we don't do any of those things to a ward. And just like, oh, I've got 4 patients. There's 2 patients who is consultant, and I'm like, I was telling her straight away, I'm sorry, I don't know how to. What that antibiotics you are asking me, I don't know how to prepare one, and I'm not going to prepare it. Remember, I said that to her. She was looking at me like, The expression on her face was like, of what use are you to me then? I could just read that expression on her face, but me, I don't care. That's me saying, I'm sorry. These antibiotics, that means I'm going to prepare 5 antibiotics. And I'm sorry. I said to her, I'm sorry. I've never prepared any before, and I'm not going to do it now. She was like, okay. And she has 2 patients. We need to remove their pacing wire. And I said, hold on. I have never removed a pacing wire before. So I will not be touching a pacing wire. So a patient, I said, I'm not going to be doing that. So she was like, okay, there's 2 patients. She's going to remove one, and then I can remove one. I said, yeah, that's fine. I will watch you remove one, and and again, the effects of what could happen if you remove a pacing wire. Pacing wire is mainly patient who has had maybe like a cardiac issue, and they've had to do some sort of electronic whatever with them. So whatever wire that is left, there's a way you remove it. There's a way you remove it, and if you're not careful, so if you're going to remove a pacing wire or what is left of the pacing wire, you need to take the observation of the patient, then remove the pacing wire, and in an hour you need to check constant. You need to keep an eye on the patient. So I said, okay, that I will watch you take one out, and then the other patient, you will stand there while I take the one other, even though I was not confident in doing so. Basically, all of the things she was going to do, I told her I don't feel confident, even though I've seen them being done before as a student, because I was actually a student on that ward. I said I've only seen them being done as a ward, on a student, as a student, but being qualified, I've never, and I'm sorry, I'm not going to start doing them because I've not received any training in regards to those things. And yes, any department you work, they will train you based on the skills that is beneficial for that department you work. So just because I work in recovery now, you are now sending me to a stroke ward. Like, how am I supposed to know what you do there on the stroke ward? I hope you guys understand where I'm coming from. So one of the things that happened was that, so in the morning, it was I went with her to go remove the first person wire. She did the first person wire. She did the first one, and it went fine. So even though I was not happy that I was sent there, because I was meant to go spend the whole day there, apparently that day was a training day at work. So I went to complain to my manager and said, no, I don't feel confident staying in that ward. So they were like, okay, let me just stay there till lunchtime, and then another colleague will go. Meanwhile, my other colleague that went, the second patient that were meant to remove the pacing wire, they removed the pacing wire, and that patient had, I think that patient had a peri arrest or something, or they had tamponade, which means that at the end of the day, what happened to that patient? They have to take that patient straight to ICU afterwards. You can imagine if that person wire was removed by a nurse that has been trained, though. You cannot imagine if it was me that have not been trained to do stuff like that. I will have blamed myself for whatever must have happened to that patient. And yes, what happens to that patient is to be expected when that wire is being removed. So what I'm saying in essence is that yes, you might be at a hospital, you might think that you are a band 6, band 7. Not be every nursing training you go remember. And yes, there have been times even while I'm looking after my patient at times, I second guess myself at times. And no, it is not because maybe I don't know what I'm doing. I want to be sure that the information is correct. So because you are a nurse now, you don't know how to do something, you go ahead and do it anyways. So you are meant to feed somebody. Instead of you to use a certain feeding tube, you're not sure of what is the feeding tube is. Why not ask? Like, oh, do you know what size of feeding tube is used for this patient? And if you've been working at that department for a very long time, you will know. You will know the go-to feeding tube. It's just like if you work on a ward and you want to catheterize a woman. Those of you who are nurses here, you agree with me that the size of catheter that is being used in a woman, in a female, is size 12. You go for the smallest one. So, for if you want to catheterize a female, your go-to, which mostly you will use first, is a size 12 catheter. You're not going to carry a size 16 catheter and say you want to catheterize a woman. No. The go of you want to go for. So now you work in that department for how long you've been working there. You don't know your go-to size of the feeding tube. And yes, it's not a crime that you don't know, because at the end of the day, maybe you had multiple patients you're looking after that day. You can go through their notes, because when we use things like that, we often keep the labels that come with them, put the labels in the notes. So if I were to catheterize a patient now, I'll put the label of the size of catheter that I've used for them. I'll put it in their notes. It has like a sticky back. Put it in their notes. So let's say that is not there. You could ask a question. You could ask your colleagues. Maybe if the person who did the last feed, oh, so, do you know what size of no? Yeah, you might think they're going to laugh at you, but at the end of the day, that is you making sure you're doing your job right. So this lady now, I don't think I need to put allegedly that she's probably one of those nurses who do not have the skills, who do not even have maybe the work ethics or the work qualification to actually go work in that department, but because somebody has coached them on interview questions. And yes, I want to be a band six. I'm a band six because at the end of the day, band six, they earn from like over 30 something thousand, I think over 35,000 per annum. And yes, nursing salary in London is higher than in Scotland. And they pay them good money. So somebody's coached her interview questions, or maybe somebody she knows that trust was the one that gave her that job, the job link, and that person had coached her, and then she went onto that job having no skills whatsoever to work in that role. You can imagine. It's just like you're a cardiac nurse, and they're asking you to read. What is the rhythm? Is that patient in sinus rhythm, or is that patient in AF, or is there an atrium? Is there a flutter, or whatever? Like I said, now when it comes to reading ECG rhythms, I can't read it because, like I said, yes, we were trained when we're doing cardiovascular system, the ECG, we have to read the rhythm of the heart, the AP vapolarization, a P wave, V wave. I can't read that shit. I can't. I know as long as it's not a flat line. If it's not a flat line, I know at least the patient has a rhythm. If it is flat line, then I know okay, that's his problem. I need to do something. But if I'm looking to work in a cardiac department, these are the things you're expected to know. If you're looking to work in a stroke ward, you're meant to know how to help people or help residents move safely. You need to understand that they might not be able to use some part of their body. Maybe they might not even be able to brush them teeth themselves. There are things that you'll be able to help them, because at the end of the day, if you work in a stroke ward, the purpose of them being the ward is obviously to rehabilitate them. So if you're working in an endoscopy unit, you will know what would take place. Patients will be given some sort of concoction for them to drink to make sure that it clears their back passage before they get to go, to do their colonoscopy and all of that. So if you're going to work in an endoscopy, it's just like you knowing how to how the how some anatomy of the the abdomen, the intestine, the big intestine, and all of these things. You need to know all of those things. Me working in recovery now, I'm practically using all of the skills I've learned in all of the anatomy system that I've learned. You know, so I know when I see a blood pressure that is LD, and if that blood pressure is not LD, I know what steps to take. I know that if I see a heart rate that is below 40, or an heart rate that is 170, that is like beating faster, I need to do something. Like you see if somebody's heart rate that is going 140, 170, 190, you're not going to keep quiet. You need to let the anesthetist know, like, why is this heart rate 190? I can tell you a heart rate that is beating at 190 beats per minute. The patient themselves they can hear their heart beating the way it's beating. So if you're a nurse looking after such patient, you're not just going to sit down and say, oh, maybe that's their numb. No, it's not their numb. Something is definitely going wrong somewhere. Or somebody is, patient came out of theater, by the time they came out and how they are still sleeping, they are not really, really fully responsive. You're not going to sit down there. You try all of you can to, arouse them, raise them up, rouse them up. At least let them say, ask them, where are you? What is your name? Have you got any pain? If they're not replying to you, if they're not vocalizing back to you, then there's a problem. You need to get the anesthetist back. And yes, it's understandable some people, maybe they have given them too much sedatives. It might take them forever. It might take them maybe at least half an hour for them to fully wake up. But in half an hour, and they are not, they are not looking as if they are going to wake up fully, even after you've done the chest rub and they are not responding, you need to be asking for help. So these are some of the things I have been trained. Or a patient comes in, they are snoring like, they are not snoring. That is their airway. That's them not taking proper breath in. So you know what to do. Jaw thrust. Because even if you are not doing it, one of your colleagues will be the one to come around and be the one to leave the jaw of your patient to say, that airway is not clear enough. You need to leave the jaw. So you get trained by the department you work at. So if you know you don't have a skill of a particular job that you are going for, please don't go there. Don't go and work there. And like I said, in most jobs, if you apply there will be some sort of training. Either you shadow another colleague for 3 weeks, or you have some sort of supernumerary, what do they call it? I can't even remember what it's called now. Like you work alongside another colleague who will be able to show you around work practices for that department to get familiarized. So now this Nonso, she has allowed all of these TikTok coaches, NHS interview coaches, to coach her to go do a job that she does not have the qualification. She does not, maybe she have the qualification, but she does not have the skills for. And I would imagine that she was trained. Maybe the training was not enough. And if that was how it came across, the management would have put her through further training. And then they ask you a question, what does the gallbladder do? You say gallbladder, they carry urine. It obviously shows that maybe the qualification you claim you have, maybe you don't even have it. I'm super happy that at least no patient came to harm while she was working in that department, because it would have been fatal. It would have been a fatal case. And then again, yes, this is going to put the wrong narrative on other Nigerian nurses. They don't go to school. Their school is backdoor. They don't go to school. Fake certificates. In it, like when I saw the comment on Facebook, like underneath the post, actually, I was like, wow. Third world country, what's it called? Their cheap labor, that the UK is employing cheap labor, blah 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 blah. So Andy said, after Asians in America, Nigerians are the most educated. Absolutely. That's why I said, you will see a Nigerian that actually go to school. Who actually go to school to read book, and school did not just pass through them alone. That they went through school passed through them, and they said them passed through school and took above, they took along with them everything school taught them. Yeah, preceptors. Thank you, Andy. Even me, like I said, even when I started my work as a newly qualified nurse, I had an in-out. It was like a classroom training for 6 weeks. After then, I was placed. I was working supernumerary, which meant I had a preceptor, just like Andy said, the whom I worked alongside for another 12 weeks. And then after 12 weeks, I was let loose. Like, you're on your own now. But still, I know if there's anything I'm not sure about, I know how to ask questions. Like, say, guys, can somebody help me here? And like, oh, what do you need? Oh, see, I want to do this. How do I do this? And because at the end of the person where they tell you, the person you're asking might not even do it often. But then you might have the experience, and it might just walk you through. There's one of the girls who used to work in ICU. She's full of knowledge. If there's anything that needs to do with some lines or venflons or something that I'm not, I will call her like, oh, come on. She will just laugh because we know she came from ICU. So they've trained her based on the services, the skills required in ICU. So now she has now come to join us in our department. So those of us that we don't have those things that she's been trained on in ICU, we are tapping off some of those skills from her, which is a plus. But then again, some of those skills I've tapped on, if I need to do something and she's not there, I won't say because I've seen her done it with me before, or I've seen her done it with somebody before that she not carry on, even though I have not been trained within my department to do it. I will need to either ask another senior member of staff to come observe or talk me through it. Like I said before, I used to be terrified of removing arterial lines. I used to be very, very terrified of removing. But now, it's something I can remove in 2 minutes. Remove it, put pressure on it for 10 minutes because you don't want patient to bleed out. Before, if I have a patient that has an arterial line, hey, if it's time to remove it, I'm always like, oh God. But now, the only one that I know that I don't want to mess with is the PIC line. I don't mess with the PIC line. I don't. Even when they are passing fluid, I don't mess with it. If I need to go and call my senior colleagues to come and, yeah, if they say we should draw blood, I'll say I'm sorry. I don't feel confident doing this. I'll just go and grab one of my senior colleagues to come and do it. Even as they're doing it, I'm watching, but still because I'm watching does not mean that tomorrow now, if they ask me to do that, we want to do it. No, I won't do it. I won't do it. There's no harm in asking questions because at the end of the day, you as a nurse, you want to be advocating for a patient, you don't want to be causing them harm. But this lady has gone on to done otherwise. Now she's lost her job, and I don't think she will ever work as a nurse again or as a dietitian again. I don't think she's ever going to be able to work as a dietitian again. God help her if she ever gets a job again as a healthcare worker. So the takeaway I want us to take away from here is this. Yes, you've been trained. Like I said, yes, you've been trained. And again, we some of us we also learn on the job. And this is while on the job as well, you are also, enhancing your skills at the same time because you come into what they don't expect you to know everything. Because there will be some cases you will come across that you've never seen before, and you'll have to like, oh man, I don't know how to deal with this. Which means you need to ask questions. There's no harm in asking for questions. And if there's a certain skill that you're supposed to have or that you're supposed to use often, and you think you're not comfortable with that skill, ask questions. Your board or your management can put you through further training. Like in my department now, there's something we call ILS. It's like a resuscitation training. We do it every year. I do that training once every year. Like, what do you need to do in case if a patient is deteriorating? And they will give you scenarios based on your department. So if I go for that training, most likely thing that is made that could happen is anaphylaxis. Yeah, people suffer anaphylaxis from whatever, maybe from anesthetics or from sedation, from whatever. And what would you do if you're looking after a patient like that? Or you are looking after a patient in recovery and the patient started suddenly saying that, oh, they started giving you symptoms of a heart attack. What would you do? Or that experience I've just mentioned of a patient that I was looking after, blood pressure was dropping, blah blah blah. Even me, with the fact that with everything I've done, I did not even think I did not even think to the fact that the patient could be bleeding. It was not until the following day the anesthetist told them that yes, it was after they did a CT scan that they found out that the patient was bleeding internally into her bones. Obviously, yes, she's losing volume, which we are giving volume and she's losing it. So, which is why her blood pressure was not stabilizing. And yes, that was how deteriorated. So they will give you scenarios and they'll ask you in those scenarios, what would you do? And you have to also we do that training once every year. And it's a mandatory training once every year. It's not a waste of time. It's because of the department I work in. Hairway is very, very important. If a patient loses their hairway or more, it will be hard though. It will be hard. And what do you do? If maybe you notice something's happening and you realize that, oh, with the way this patient is going, they might lose their hairway. You put a Gedel in. You put a Gedel in. And yes, in a situation like that, what size would you use? It's just not about putting it. You don't just put any size of Gedel in. What size would you use? There's 3, 4, 5, 6. Most common one we use is 4. The orange one or the yellow one. The most popular one we use is the yellow one. I think that's size 3 or something. And you should know how to put it in. At least that way, before the anesthetist come out of theater, you've already secured the airway for the anesthetist, and then the anesthetist take over. So, as a fellow nurse that is watching me out there, your years of experience does not matter. Because at the end of the day, life happens to some people, and it might take their mind off work. It might mean that maybe they might not be concentrating because they're passing through a phase, which may mean that in a way they are slagging behind. There's no harm in asking questions, asking for help. You might think they're going to laugh at you, let them laugh at you. But then again, you're protecting your patient and you're also protecting your PIN, your nursing license, your dietitian license, your healthcare license. You are protecting that as well. And as a nurse, you want to always advocate for your patient because a patient is vulnerable enough for the fact that they are in hospital. For the fact that they are in hospital, you now want to carry your incompetent self to come and look after a patient that is already vulnerable. Like, how are you doing them good? How are you doing them good? So, guys, good luck to Nonso. Good luck to her. And to those of you who are depending on all of these NHS coaches on TikTok and on Facebook, it's not that hard. Again, if you attend an interview and you don't pass it, there's going to be many more interviews. It is from your mistakes you learn. There's going to be many more interviews. The worst you missed in the last time, yes, if you go to an interview, you don't pass the job, ask for feedback. What did you not answer right? They will give you feedback. So that feedback is what you can use to prepare yourself for the next one that you go to. Because you lost the interview or because you did not pass the interview, it's not the end of the world. So if you're at work and you've been asked to carry out a task and you're not confident about doing it, ask for help. Or if there's a training and you think will benefit you greatly in your line of work, speak to your line manager and say, you know what, can you put me forward for this training? Because at the end of the day, this department, they get funding for all of this training. In as much as you're caring for somebody, you also want to look after yourself as well. So I hope this thing that NOSO has done, like I said, it's going to put lots of scrutiny on new nurses that are being recruited now, especially from Nigeria. And you guys know they've always been scrutinizing Nigerian nurses for a very long time. So I hope this is not going to change, whatever it is about Nigerian nurses. And yeah, so that's just what I've got to say there because, like I said, I am very, very passionate about my job. And why I'm passionate about it is the fact that I have had 5 kids, or let me say, I've had 4 children on the NHS, and I don't think I regret any time at all that I was in hospital having my kids. I was well looked after, I was well advocated for. When one of my sons had a major surgery, I was wowed. He had a major spinal surgery. I was wowed by the way he was looked after, even though the surgeon was like, oh, by the way, mom is a nurse, even though I tried to hide that. And for the fact that he already told all the nurses and all the staff that were looking after my son, all the nurses were doing everything by the book. At that times, when I see them, when they were doing past sliding, when they are transferring my son and all of that, I would just look at them like on a normal day. If they did not know that I say I be nurse, they don't go do these things the way they do them. But then it goes on to show that some people, yes, maybe that's how they do. You know, it's not all tasks that you nurse do that they wear gloves. But with my son, I could see that they were doing things the way if I was there, that's how I would have done it. Or if I was looking after a patient, that's what I would have done. But then, yes, like I said, they were doing everything by the book. At some point, I even had to help them. They were going to pass slide my son. But like I said, he had a spinal surgery, so there's a way they will have to transfer him. I had to offer to help. And they were like, "Oh, mom, are you sure?" I'm like, "Yeah, why not? I will hold his leg. I know I will keep his leg steady, and you guys can do what you want to do." So, and like I said, I'm very, very passionate about my job, and why I felt like nursing is part of me, and it's going to be part of me because I've benefited from the system. I had my children, my son had a major surgery, even myself, healthcare. So when I see stories like this, I just have to come here and input my own. That in whole, nurses have been trained, or you are trained based on where you work, on the department you work. So if you, like I said, if you work in endoscopy, you will want to know all of the things about the back passage, all of the stomach and stuff like that. If you work in the cardiology ward, you want to know everything. You want to know the anatomy about the respiratory system, the cardiovascular system. You want to convert, make sure your knowledge is up to par in that in regard. So, and if there's anything you think you don't know, ask for help, ask questions. If there's a training available in your department or in your hospital that you think you will benefit from, ask to be put forward for the training. There's no harm in asking. I would rather you ask question than put a patient in danger, and also yourself. Anyway, guys, I'm gonna go. I said I've been here for an hour already, so I'm gonna go. I just hope that if any of you are watching this video back, you're able to take 1 or 2 lessons here. Don't depend on any of these coaches to do your NHS interview for you. Don't depend on any of them to write your CV for you. Curate your CV yourself and prepare yourself for that interview. Don't go and be paying anybody to help you format your CV. You don't need any of that. Because at the end of the day, the job you're applying for, they already told you what they are looking for. And for the fact that you have applied for that job, it's because you believe you have the skills. It's because you believe you have what they are asking for. That's why you're going for the job. So if you don't have what they're asking for, don't bloody go for the job. Don't go for it. Anyway, guys, I don't want to waste much of your time. Thanks so much, each and every one of you who have been here. Let me read the last comment here, and then I'm gonna go. And he said, "Them talking about cheap labor is out of jealousy." I did not even bother replying any of them because if I do, they would. You all know that the way they would turn to you. I did not even bother replying. I just read and I just move along. Bamidele said, "Good point. Know your limitation. To exactly know your limitation. I would rather you say no, I can't do it, than do it and you cause harm because that one, that is, you know, that is the way you don't want to find yourself." Vivian said, "People like this is why a lot of people buy on the operating." Exactly, yes. You know what? There was a time one of the anesthetists at my work shared a story of how a patient suffered anaphylaxis to one of the antibiotics in theater. In fact, the story is long. Maybe I will share it another day. And at some point, they thought they were going to lose the patient, but eventually they were able to, get around it after how many hours trying to find, whatever. Because apparently the patient said she was not allergic to it. It was not until after they've applied, the antibiotic. Because yeah, there are some antibiotics that people cannot take, and there's a common one. I think there's I can't remember. There's a lot of antibiotics that they use, but there's a particular one that they use a lot in my department. So they will always find an alternative. That's why even as a patient yourself, you should know what your allergies and stuff. You should know what you're allergic to. For me, I don't have an allergy, but I have sensitivities to ibuprofen. If I take ibuprofen, it upsets my stomach. Like it will be as if it will be like say person they put knife to my stomach. So anything ibuprofen, I don't take it. So I am sensitive to it. I don't take it. So rather than take ibuprofen, I will need to get something, another muscle relaxant. And I remember when I went to have my surgery, I told the anesthetist that because I'm familiar with the anesthetist, and I said, "Come, Oga, I must wake up. Oh. I am sensitive to ibuprofen." And he was like, "In surgery, they use ibuprofen as a muscle relaxant. In most surgeries, that's what they use it for." So when I told him, he was like, I would start with it because I told him I've got sensitivities to it, no an allergy. See, if I said I have an allergy, they won't even give you a tiny bit to try it out. They dare not. But because I said I have a sensitivity to it. So immediately I mentioned, they were like, "Okay, we're going to start small. If we notice any effects or anything, we won't give it. We'll start, we'll change it." When I came back and he saw me, we're like, "No, I gave you a tiny bit and I think you were fine." But still, if I were to go to hospital again for surgery, I will still tell them I am sensitive to ibuprofen. But that story of patient getting anaphylaxis from antibiotics in theater, when I heard that story, I was terrified. But eventually, they were able to save the patient. So yeah. Edith Boss said, "You know your stuff. You should do weekly nurse classes on Zoom and charge something." Edith, everything is not about money. Everything is not about. I mean, me that yeah, no. Like I said, I've only been qualified 3.5 years. I don't know it all. I read articles. Articles that I'm interested in. So yeah, I won't say that skill or what I know is up to the level that I want to charge anybody. No, I've got some nursing videos from when I just started. So if anybody's interested, they are still on my channel. But yeah, at once in a while like this, I like to just chip in my a little bit that I know. So thank you so much. I'll take that as a compliment, actually, Eddie. Thank you. And they said penicillin and vancomycin are the big ones. So vancomycin, um, I've seen that being used in ortho cases where there are revision. So maybe if there's an infection in a previous orthopedic surgery and the patient had to come back for a revision, they often use vancomycin. So my department, we don't use vancomycin a lot. We don't. I can't remember the one that we use. Penicillin. I can't remember the one. I can't remember it off my head now. But yes, they often, like, patient often get antibiotics before they come out of surgery. They often use, yeah. So what AI did you I use paid version of ChatGPT. I just I wrote my title in, and then I asked the ChatGPT to generate me a thumbnail based on the title. So, and then I think I did a few, and then so I asked it to do to generate me a thumbnail based on the title, and use elements, elements that depict healthcare, cult, and stuff like that. So that's why you can see the body system, the human body at the back, the dismiss fake physician and stuff like that. So yeah, Andy said that causes reactions. Yeah, so there's a lot of antibiotics anyway, and all of it. So that's why at times it's always good that patients often let their anesthetists know that they've got allergies, so that if they've already prepared a certain antibiotics, they can switch it and use one that they know will be fine. So yeah. Anyway, guys, I'm gonna go. I hope those of you who are gonna be watching this video, I hope you can take one or two things away. There's no in this country, there's no backdoor to anything, especially if you're going to be working directly with human. If you're going to be working directly with people, you can't use backdoor. You can't use backdoor. So and again, for me, like I said, my nursing career, I take it diligent, like I take it to heart because I know what my eyes went through when we're doing. I did unpaid 2,300 hours. I worked 2,300 hours unpaid. So I cannot let all of that struggle now go down in vain when asking a question could have saved it. You know, 3 years of nursing degree, it was not easy. I've shared my story of at times where, at some point I cried during my training because it was too overwhelming for me. It was difficult. It was hard. Waking up very early in the morning, 4 o'clock in the morning to get ready for placement. It was hard. And yes, I mean, COVID started a month after I started my nursing degree, and a lot of my colleagues they dropped out, but I kept moving because I was like, no, I can't stop now because if I stop, I don't know what I'm gonna do. So yeah, yeah. So COVID started a month after I started my nursing degree, and even during that period, I had to homeschool all of my kids because COVID we're all locked down for how many years, and schools were shut, and all I can imagine studying nursing and homeschooling 5 kids. It was hard, but I was like, no, I'm not dropping out. I must finish this course. So yeah, my nursing career means the world, means everything to me because I worked hard for it. Is it the essays? Is it the exams? I cried though. That's what I want to write essay at times. I will not have a freaking clue. Most of my mates, when we start lectures or when during our lecture week, which is 12 weeks, when they start, when we start the first lecture in the first week, second week, some of them are already, already. If you give them an article to write an exam or write a maybe a 1,000 word essay, they will write it. Me, maybe it's by the 10th week that I'm starting to make a sense of what my lecturer has been asking me to do or what the essay that we're supposed to write. You know, most people will have grasped what we're supposed to do in week 3 or out of week 12. But me, maybe it's week 7 that is starting to make sense what I'm supposed to be doing. So all of that struggle, you will not allow when you could have asked the question, could have saved it. No. So anyway, guys, I'm going to go. Thank you so much to those of you who have been here. And I hope any new nurses out there or any nurse out there, if you're struggling about anything, please ask questions. Please ask questions. There's no harm, there's no shame in asking questions. You ask a question, you get an answer, and then it helps you with your skills as you go by. And also, as a nurse as well, you might say, oh, because you've already qualified, you still need to cultivate the habit of enriching your knowledge. You might find I read some health journals once in a while, and me saying this, I don't do it all the time. Maybe once a week, I try to read something relating to my work with my work practice. So it might be a certain procedure, maybe like a wedge or like a thoracic procedure because we look after thoracic patients. I might look at what is a lobectomy, what is a thoracotomy. I look up stuff like that, or maybe while I was at work last week, there's a certain procedure that was thymectomy. I've never heard of that surgery being done before, but we've had a few being done in the past few weeks. So I took my time over the week. I went to go read up on thymectomy to read what it's all about. So try and maybe read a journal article relating to your field. It might not be a big ton, or it might maybe just be an A4 article. You know, I still access all of my university libraries. I still have access. Yeah, I validated last year September. The validation is once every 3 years. So I validated last September. So enrich yourself. Read an article. It might not be a 4 pages or 5 pages. It might even be an A4, but just a page like that. Read it up and save it. I still have access to all of my university library and stuff like that. So if there's any journal I'm interested in, I know how to go grab all of these journals and I read them. If it's something I can save, I save it. So don't say because you're now qualified, you're making the money. We still need to keep learning every day. I just recently did my ECG training. I just did my ECG. Yeah, I did my ECG training. How to take ECG in case of emergency, and which we do once in a while. So I just completed my ECG training there. Was it 3 weeks ago? And then again, I've just done my ventilation and cannulation training. I did it 3 years ago, but I've not practiced. So, and yes, most anesthetists, they are the ones that put all of their venflons in themselves. So I've not had a chance to practice. So now that I've just completed another training, I'm hoping they will send me to somewhere on the ward to go do half a day so I can cannulate patients and take blood. So that way I can, get my competency sorted. So yeah, read time. It might even be something you find randomly. Just look it up and read. Yeah. Viva said, I wonder if people you've cared for ever. Oh, they do. I've received cards. I've received box of chocolates. There was a patient that I looked after. Was he almost 2 years now? She was a thoracic patient, and she was I obviously I cared for her. And at some point she was like, "Oh, you've got beautiful skin. What do you use? What you need to tell me what you use." And I'm like, you need to get better first. And yes, she was in a lot of pain. But I've looked at her for about 3 hours, and then I got her to go to HDU, and she was like, by the time before we got, we were like, well, Wemi, you need to tell me what you use for your skin. Your skin is beautiful. Your skin is glowing. That was what she kept saying. When by then I've already been able to help her control her pain. So by the time I got her to HDU, I actually went to go and look for A4 paper and wrote down my moisturizer, my vitamin C serum that I used. I wrote it and how to use it for her. I did not think anything of it when I wrote it. And she was like, "Come, Wemi, if I need to send you a card, where should I send it to?" She was asking for my full name, my address. I'm like, you know what? When you get to the ward, address it to your ward, but put my name on it and say PACU. So I told her to put my name on it and say PACU. So that way, if it's being received on the ward will send it to my department. I did not think anything of it. And then a few weeks later, my senior nurse called me. She's like, "Oh, Wemi, by the way, I have something for you." And I'm like, "Me?" I thought I was in trouble. Oh. And then she handed me an envelope, a white envelope. I'm like, "What's in this white envelope?" So it was a card to say, it was addressed to me, my name, to say, "Thank you so much for looking after me. You ensured I was comfortable." And then she said she included, if I still have that earring. She made a jewelry, a earring, and necklace, and she said it was her granddaughter who made it, and she just wanted to present me with it. I still have it today, and I use it as part of my validation last year. So we get cards, we get biscuit, we get thank you cards, and all of that. We get it often. Yeah, we get it often. So that's why it's always important when you're looking after a patient. You introduce yourself. "Hello, my name is Wemi. I'm going to be looking after you today while you're in recovery. If you got any pain, you introduce yourself. And again, if the patient is awake, chat with the patient. It could be, oh, have you traveled far? Have you been waiting for this surgery for a very long time? And also that way you are helping to find out, or you are also looking to find out if they are in pain. Because if they're in pain, you could see they might not want to chat with you and stuff like that. So yeah, we do. I actually get it. Yeah, we do. Guys, I'm gonna go. Adefunke, I'm just leaving. Oh, welcome. How are you? I'm just leaving. If you have the chance, please feel free to watch the video back. First said that's nice. Thank you so much. Vivian said, "Hey, yeah, that's really nice to hear. It encourages heroes like you. The Dudu nurses in the UK have been complaining about abusive patients, so I'm glad to hear you are treated well in Scotland." Since I've been where I worked, I've only had to deal with a patient who was not really abusive. They just woken up from a 5 hour surgery, and they were throwing punches and all of that. It took four nurses and a very strong anesthetist to actually calm the patient down. So I mean, I love the fact that the anesthetist stayed. It was giving him something to make sure that to calm him down. But as long as that wears off, the man is throwing punches and all of that. At some point, we're like, "These nurses are trying to help you. Stop throwing punches." And then at some point, it took almost half an hour to stabilize him because the man was just He just woke up from a long surgery. He was throwing punches and all of that. It was late at night, and yeah, I don't think I've ever come across a patient that's been, abusive or anything like that. I think I've only ever come across one that said they didn't want me to look after them, and I respected their decision. I respected their decision, so I didn't take it personal or anything like that. So yeah. So anyway, guys, I'm gonna go. Thank you so much for being here. And like I said, Nonso, I hope you've learned a lesson, and please don't do the same thing as Nonso. If you don't have a skill, it might not even be nursing. If you don't have a skill if you don't have the skill for a particular job that you're going for, please don't apply for it. Allow the people that have the skills to apply for that job and get it. Don't go and be lying on your CV that you have a social training when you don't have it. Because at the end of the day, if you've lied that you have a skill, the hospital that you're going to work, they will not even know how they want to help you. They will not even know. So, like me, when I started my job, I was a newly qualified nurse. I went straight from uni straight into my job. So I've only taken on board all I've learned from uni. And while at uni, all of these things they teach you, they are just surface things. We learn all the practical things in the hospital when we go for our training. However, the department I am going into, I don't know what they would do there. I don't know how the services run. So when I started in there, they know the curriculum of the unit that I've come from. They were able to put into together all the skills that I'm going to need in that department I'm going to be working at, and they trained me in everything. They trained me in everything. One thing though, I am very heavy-handed. When I'm opening vials of, all these vials of fentanyl, the bottles they are quite tiny. I'm always praying not to shatter the box because I am very heavy-handed. When I'm trying to make some IV infusions up, when I'm opening those tiny vials, I've cracked them a few times because my hand is strong, well. But still, I'm sure trying different skills to make sure that I don't crack the bottle. But yeah, but still, I know what I'm supposed to do and I know how to keep myself safe. So all of that. So yeah. Anyway, guys, thank you so much for being here. I really appreciate you all. Um, there's no harm in asking questions if you're not competent enough to do something, or if you're not confident enough to do something. Ask questions, ask for help, rather than doing it and getting into trouble and somebody crying or suffering major health issues because of your actions. You don't want to do that. Thank you, guys, and I hope we all have learned one or two things from this experience so far and from the story of Nonso. And let's all just be careful out there, okay? In the midst of us trying to make a living for ourselves, let us be very, very careful and avoid all of those NHS coaches on Instagram, on TikTok, or on Facebook, or on YouTube. Avoid them. Go for these things yourself. Do them yourself, okay? Have an amazing week ahead, guys, and I will see you all later. Thank you, Handy. Thank you, Vivian V. Thank you, Ford. Thank you, everyone. Eddie's Ball. Thank you. Mr. Michael, thank you so much. Mr. Sunday, thank you, everybody. And I shall see you all in the course of the week. You guys might probably get some of my car videos while I'm driving. But yeah, I'll try and upload something in the course of the week. Have an amazing Sunday night, and I will see you all later. Bye, everyone.
Five, living life, feeling alive. From kids to culture, news to tea. Real talk, real life. Come vibe with me.